Various lipoproteins that circulate in the plasma, and shown here is just kind of a nomenclature of lipoproteins that start with chylomicrons. So when we ingest some fat with our food, we absorb the food as food fat as chylomicrons, and chylomicrons are broken down into the liver eventually, and they become smaller particles called remnants or chylomicron remnants. Now remember, this has an apoprotein inside the lipoprotein called ApoB48, which is a very different apoprotein than what we produce in the liver in the form of a particle called VLDL, or very low density lipoprotein, which is a apoprotein called apoprotein B100. So just remember that particles that contain ApoB100 are known to be very atherogenic, although particles with ApoB48, once they're broken down into remnants, they also become atherogenic. The VLDL particle, once it is produced from the liver, is converted into smaller particles called IDL, or intermediate density lipoprotein, and eventually LDL, called the low density lipoprotein particle. In addition, there's also a small apoprotein called lipoprotein A, or lipoprotein little a, and finally a different type of protein that circulates in the blood called the HDL, or the high density lipoprotein. As you all know, that epidemiologically we know that HDL is a protective factor. It actually reduces the atherosclerosis risk, as shown on the observational studies from many parts of the world. Now, when we measure LDL cholesterol in our blood, which is the main atherogenic particle, this includes LDL as well as IDL and LP little a. These are all measured as LDL cholesterol when we order a test for lipoproteins. We also should remember that VLDL and IDL are also atherogenic, even though they're mainly containing triglyceride and not so much cholesterol. So one way to measure all the atherogenic particles is to really look at all the particles that have ApoB100 as shown here, and we can calculate them as non-HDL cholesterol. So what is non-HDL cholesterol? I'll come back to that later. But if you measure total cholesterol and you order triglyceride and HDL, as we often do in clinical practice, then you can just simply calculate non-HDL by subtracting HDL from the total cholesterol. So indirectly, it is a rough way to measure all the lipoproteins, which are not easy to measure clinically. But if we just calculate non-HDL cholesterol, that is a very good index of atherogenic particles, in addition to LDL cholesterol, which is the most atherogenic particle, which we always measure. So just keep that information in the background when we talk about various clinical trials and the current state of our understanding of lipoproteins. Now, very quickly, I just want to say that there is an enzyme called HMG-CoA reductase, which is the key rate-limiting enzyme in the process of cholesterol synthesis. So cholesterol synthesis is a very complicated process. It goes through 27 different steps biochemically, but starting with acetyl-CoA1, when the HMG-CoA reductase converts the acetyl-CoA1 to HMG-CoA1, that starts the process of cholesterol synthesis all the way down to cholesterol and some other chemical agents such as isoprenylated proteins and ubiquinone. Ubiquinone is also known as coenzyme Q10. Which some people take in order to prevent some of the complications from statin therapy. Okay, now so much about just basic biochemistry. I want to get more into clinical aspects of our care of patients with elevated lipoproteins. So when it comes to treating cholesterol and reducing the risk for cardiovascular disease, I think by now you all know that statins are the most important drug. Now, when I mentioned a minute before that cholesterol is synthesized, where they block the action of HMG-CoA reductase, and therefore they totally block the synthesis of cholesterol down the line. That's the mechanism through which statins work. They were discovered many, many years ago, and now they're, of course, state-of-the-art therapy in patients who have elevated cholesterol. So they were first available in 1985, and so we had them for about 32 years. So in the past 30 years or so, we've had a lot of clinical trials that have proven that statins reduce major cardiovascular endpoints and even mortality. So shown on this slide is a large meta-analysis which was published several years ago. You can see that in the 21 different statin trials with large number of patients, when you give a statin to a patient and you lower the LDL by say 40 milligram percent, or 1 millimole. I'm not sure which unit you use in Cameroon, but conventionally we say 40 milligram percent reduction in LDL cholesterol will give you about 20 to 25% reduction in major cardiovascular endpoints. However, if you use a more intensive statin therapy, not just 10 milligram atorvastatin or 20 milligram simvastatin, but let's say much more intensive statin therapy, you can lower the risk by additional 28% by going from less intensive to high intensive statin therapy. So that's an important point, because these days we believe that lower the LDL, the better the outcome. And I'll come back to the newer guidelines. And finally, statin trials have shown that not only they reduce cardiovascular events, but they also reduce total mortality. Shown here, in 5 years, we reduce total mortality by 10%, which is statistically significant. So here are the new guidelines that came out from the American Heart Association and American College of Cardiology based on various statin trials. And they suggest the following. That if you are above the age of 21, and if you don't have advanced heart failure or advanced kidney disease, such as those going on hemodialysis, one should think about treating LDL cholesterol in 4 different groups. The first group, shown on the left, is those who have clinical atherosclerotic disease, and there is no question that they already have advanced atherosclerosis. These people should be treated with not any dose of statin, but high-intensive statin therapy, which I'll define in a second. On the other hand, on the extreme right is the people with LDL cholesterol, which is very high, above 190. And these people, you know that they have such a high LDL cholesterol that many of them, if not most of them, will end up getting cardiovascular disease. These people should also be treated with high-intensive statin therapy in all adult patients. So those are the 2 groups where there is no controversy that high-intensive statin therapy is very helpful. Shown in the middle 2 are the 2 primary prevention groups. On the right side is the group with no diabetes, and if these people are between the age of 40 and 75, and the LDL cholesterol is between 70 and 190, let's say 70 to 189, calculate the 10-year risk based on a new calculator that was brought out by the American Heart Association and ACC, which I'll show you in a second, which is better than the old Framingham heart disease risk calculator. So by using this calculator, which is more accurate, 10-year risk calculator, if the risk is more than 7.5% in 10 years, then you need to treat these people at least with moderately intensive statin therapy. And one can individualize treatment, and some of these may have to be treated with high dose as well. On the other hand, we have patients with diabetes who have the highest risk in primary prevention, even when the cholesterol is not very high. So these people, age range 40 to 75, again, LDL cholesterol 70 to 189, calculate their risk. And even if the risk is less than 7.5%, regardless of the risk, in other words, give them at least moderately intensive statin therapy. But if their risk is more than 7.5%, treat them like you're treating people with LDL cholesterol above 190. In other words, give them more intensive statin therapy as much as possible. So these are the guidelines which we've been following lately. Although again, there is some controversy because these guidelines suggest that just go by the intensivity of the treatment, regardless of the cholesterol goal. Remember, in the old days, in the ATP3 guidelines, we used to say there should be a goal. LDL cholesterol less than 100 for moderate intensive risk, moderate risk people, and LDL less than 75 or 70 in high risk people. And according to these new guidelines, that may not be necessary if you know the person has a risk depending on their 10-year risk calculator. Okay. Okay. So what do we mean by high intensive and moderate intensive statin therapy? High intensive statin therapy is defined as a statin therapy that lower LDL cholesterol by approximately 50% or more from baseline. Okay, and that kind of therapy is, for example, atorvastatin, not 10 or 20 milligram, but 40 to 80 milligram. So patient comes in with cardiovascular disease already present or LDL cholesterol above 190, you need to think about giving them atorvastatin 40 to 80 or rosuvastatin 20 to 40 milligram. In all other patients, when you're looking at moderately intensive statin therapy, you are aiming to get their LDL cholesterol by a statin dose, which will lower the LDL cholesterol by 30 to 50% on an average from baseline. This will be achieved by atorvastatin 10 to 20 milligram, rosuvastatin 5 to 20 milligram, and so forth, so forth. Simvastatin actually should not be less than 20 to 40. Pravastatin should not be less than 40 to 80 in order to achieve those kinds of reductions in LDL cholesterol. So again, these are suggestions, these are guidelines. You may or may not need that much therapy. You can follow the patient and see if you get to the 50% reduction from baseline or not, and then decide on the therapy. Because in some ethnic populations, these goals can be achieved by lower dose. This is just an average, what was discovered from the various clinical trials. And again, in these guidelines, it is not necessary to follow the LDL goal, which has been a point of controversy, because we still want to follow patients with their LDL cholesterol level in order to make sure that they're taking their drug and the adherence to therapy is good. Other guidelines actually do not necessarily abandon the LDL or non-HDL goals. Now, this is the risk calculator. For those of you who want to calculate the risk every time a patient comes to you who is not yet on statin therapy, you can check their risk as baseline. This is the calculator that I mentioned. You can download it. It's available on americanheart.org. I carry it in my iPhone because it's very easy to download as an app. And you can see here, you punch in certain things like gender of the patient, age, race meaning African American or white American or white people. You can see that they did not have enough data from the other ethnic population like Hispanics or Asians. So if you're not African American, you should consider everybody white according to this classification, which you can see is somewhat by default. Then you add in total cholesterol, HDL cholesterol, systolic blood pressure. Is the patient being treated for high blood pressure? Do they have diabetes or not? And are they smoker or not? So by doing this exercise, you come up with a 10-year risk shown here, and you get a number. In this particular case, I'm sure it's not easy to see for you, the risk was 13.3%. So this patient, even if he's not diabetic, would be a candidate for intensive statin therapy. Okay, as I mentioned, not all well-known organizations follow this paradigm, and many organizations like the European Society of Cardiology and National Lipid Association in the US, shown here, still follow the older guidelines, which have been revised to point out that you should go by the number of risk factors and go by the treatment goal, both LDL goal and the non-HDL cholesterol goal. So shown here is, for example, a patient who comes in who has, let's say, two major risk factors. Their goal of LDL cholesterol should be less than 100 and non-HDL cholesterol less than 130. Non-HDL goal is always 30 above the LDL cholesterol goal. And if you are considering drug therapy, if the patient's LDL is still above 130, you must start drug therapy. Although in many high-risk people, you may want to start drug therapy even when the LDL is above 100. In people who, for example, have very high risk, such as those with diabetes, with cardiovascular disease, those are people with very high risk, or those with existing cardiovascular disease, then the goal of LDL is less than 70 and non-HDL less than 100. And people who are above these goals should be treated with intensive statin therapy. There are some patients with diabetes who may have only one other risk factor, one or none. Hard to find those people these days because most of them have hypertension, history of smoking, or other risk factors. So they fall into the very high risk category. But if there are some with, let's say, short duration of diabetes with only one other risk factor, the goal will be less than 100 and less than 130 respectively. Now, there are some side effects of the statin therapy which make it difficult to intensify statin treatment, and you all know that. So this is the major stumbling block, where in spite of our major effort to intensify statin therapy, we end up with one problem which is very common, and that is muscle pain or myalgia, or in rare cases, myositis. About 10 to 15% of patients have significant myalgia when you try to intensify statin therapy, and it's a dose-related phenomena. So this is a practical problem, and we need to have some alternatives in mind when that's not possible. And I'll mention to you what are some of the strategies to overcome these side effects. So we don't know the exact mechanism of the myalgia, probably a mitochondrial effect in some cases, or a genetic basis of these side effects, but this does happen. The second problem is, let's say you have a patient with no diabetes and you start them on statin therapy. Recently, it's been brought up in various statin trials. There's a small but significant increase in the risk of developing new diabetes in someone who does not have diabetes yet. So that's not such a nice thing. And in intensive trials, in fact, there was further 12% increase in new diabetes because more intensive statin therapy, more likely they may get diabetes. But remember that even those who get diabetes, even in the intensive statin trials, there is a 16% decrease in the incident cardiovascular disease. So just because somebody has high risk of developing diabetes, one should not withhold the therapy if they also have high risk of cardiovascular disease, because the benefit is much greater than the small increase in the risk of diabetes. One point that needs to be made here, that most of those who develop diabetes on statin therapy already have pre-diabetes. So you need to educate these people and need to tell them how important it is to change their lifestyle, to lose some weight, follow their diet, and exercise regularly in order to prevent the eventual development of diabetes, as you would in a non-diabetic person anyway. So to put it in perspective, if you use intensive statin therapy or any type of intensive, moderate or intensive statin therapy in, let's say, 200 people who are treated over the course of 5 years, you will get one new case of diabetes. But at the same time, in the same period of time, in the same 200 people, you will prevent 5 new cases of cardiovascular event. So that shows that the risk-benefit ratio of statin therapy is in favor of using statin therapy when somebody is at high risk for cardiovascular disease.